On behalf of CAHO, we welcome all of you, our panelists, our moderators, our delegates to this webinar on COVID-19, Are You Immune? Over to you, Dr. Seema.
I'd like to wish you all a very good afternoon. And we are all facing professional and personal challenges due to the COVID pandemic. And it has taken hold of our lives inexorably. And with the second wave not yet totally quelled, we are still unsure when the third wave is going to confront us. Hence, we at CAHO decided part of this, presenting this panel discussion. And the idea is that we attempt to address the areas of concern, what we have learned since December 2019, and especially the uncertainties that have been brought forth by the second wave. I am blessed with a very, very special team of professionals, and 3 of them are moderating the session. Over to the moderators for this session. Thank you so much for being with us.
Yeah, good afternoon, everyone. It's time we begin with the webinar. I would first like to ask Dr. Sanghamitra Datta, who's a microbiologist. Ma'am, I would like to know what are the various COVID antibodies, just an overview of all this for all those who have joined here, may not just be from the lab, but maybe clinicians also. And is there any difference in antibody testing among vaccinated individuals versus those post-infection? And when should these antibodies be measured? So if you could throw a light on all this.
Thank you first, organizers, for having me here. I hope I'm audible. I begin by saying my first line is, right sample at the right time will give you the right results. Being a diagnostician, I think that's the thing we all believe in. Now, coming to the question, I would reiterate what CDC says is, seroassays are supplement to molecular tests, right through as the disease progresses. So the median time for seroconversion is 9 to 10 days from the symptoms which appear. And so once the antibodies start appearing in the patients, the molecular test sensitivity decreases, the viremia goes down. So following 10 days of infection, it is the seroassays which are more sensitive than the molecular assays. Now, there are different kinds of seroassays. One's a platform which tests only for IgG. There are sometimes seroassays only for IgM and seroassays which are meant to be tested for all total antibodies. Now, coming to the sensitivity, as far as there are many physicians, they tell that after the PCR is negative, and the patient is having CT symptoms of COVID, and still we don't know what to send. So that's when timing is important. So if the patient's symptoms is past 10 days, the best test to be done is the serological tests. And ideally, the immune response is a very dynamic process. Sometimes the first immune antibody which comes up is the IgM antibody, which is a primary immune response, which comes up within 10 days, subsequent to which within 2 weeks, we start seeing the IgG antibodies. That's a very theoretical thing, but many patients, they don't have an immune IgM at all. So they might come up directly with IgG antibody. To having seroassays done with single assays, like which focuses on only IgM and IgG, might not be as sensitive as having a total antibody assay to diagnose an infection. This is very important that everyone should ask for a total antibody test when they need to diagnose an infection further into the disease. Second question, part of the question is what kind of immune response is generated by the vaccinees and by the patients, and which test to be done. Now, the immune response is the same in case of the patient as well as vaccinees. We do have a primary immune response, which generates the IgM antibodies. And then we go in for the secondary immune response, wherein the IgG antibodies are generated. However, there is a difference. In a natural infection, the antibodies are generated against the entire component of the virus, both the non-structural and the structural proteins. So you have antibodies against the envelope, antibodies against the nucleocapsid, antibodies against the spike protein, antibodies against the matrix, antibodies against the entire non-structural proteins. Now, all these antibodies may not be neutralizing, but you do generate antibodies to all these components of the virus. But in a vaccine, the vaccine generates antibodies only against the component of the vaccine the immune system is introduced to. For example, if in a Covishield vaccine, the immune response is mounted against the spike protein because that's the component which is being introduced to the immune system. So the vaccine only generates antibodies against that component of the virus which the vaccine has artificially been introduced to the vaccine. So that is the difference between the antibodies, and the antibodies which are mounted, the vaccine component is always more immunogenic, and it generates a lot of antibodies, neutralizing antibodies, which helps to neutralize the virus. So a vaccine will have a lot of neutralizing antibodies, which will help it to fight against the virus. Now, the third part is how often do we get these tests? When should it be measured? Now, CDC and WHO hasn't laid any guidelines as to when to measure it. According to CDC, once you have taken a vaccine, you are 80 to 90% protected. You needn't go on and check in for or get a test. That's what CDC says. But however, there are many studies which are being done, many projects which are being undertaken to assess the amount of neutralizing antibodies which are generated. Are they actually neutralizing to the virus or not? That's also the studies are being done. And to maintain a semblance in the study, they have done on regular intervals, like 6 weeks, 6 months, 1 year, to see the presence of neutralizing antibody. But whether they are present or not, in spite of that, they say the person is 80 to 90% protected to the severity of the disease. At present, I can only say that. I can't say that you're protected against infection because there are many post-breakthrough infections after vaccination. So there is no set standard timing as to checking for these serological titers. So that's it. I hope I've answered the question. Or
Yes, of course.
Yeah.
So basically all this immune response is dynamic, and of course, the role of testing is so important, especially determination of all these antibodies to check the immune response.
Dr. Abbas,
Yeah.
you have been actually looking after the whole of Uttar Pradesh in terms of COVID testing. And I would like to direct the next question to you. So how do we compare titers of anti-spike protein antibodies versus the neutralizing antibodies? And can a high antibody titer invoke a false sense of security? Is it possible to define a protective titer? Or is it that anything present protects you to whatever extent it does?
Thank you, Dr. Seema, for your nice introduction. And I must compliment you and the organizers for organizing this wonderful webinar. And so many stalwarts you have assembled over here. And I hope that the deliberations will be beneficial in the long run, because many questions are popping up regarding this COVID and the immune response and the immune protection which people are getting, for example, after an infection or after vaccination. Now, as far as you said that how to compare the titers of anti-spike proteins versus the neutralizing antibodies, many studies are being conducted. And we need such studies to compare, although it is not that easy, because the gold standard, that is the plaque reduction neutralization test, is a bit cumbersome, and you need viral culture and all that. So that becomes, and you require certain facilities like, for example, BSL-free lab. So it is a bit difficult, and many new things are coming up, and there is a need because, as Dr. Datta has very rightly pointed out, that knowing about the neutralizing antibodies is very important and vital, and we must and we should go in for the comparison between the anti-spike protein antibodies, like for example, because the Covishield is specifically for that vaccination is for the spike antibodies are there. So, but still, lot much needs to be done in this area. And as you have pointed out, that this high titer invokes a sense of security or false sense of security. Antibody titer is very important and vital. And yes, it do give a sense of security if the titer is high. But with COVID, you can't say lot many things with confidence. And as we are seeing that people who are infected and then vaccinated, still they are getting the infection. So lot many things are there, and that's why high antibody titer does not necessarily give you a security for subsequent infection. So a bit of caution has to be there. But yes, antibodies are important, and generation of antibodies is vital for future protection. Now, as far as the third was about the protective titer, I think you asked that is it possible to define a protective titer? As of today, not many platforms are there for the measurement of antibody titers. So I don't think there is one such assay which can tell you, because not many kits are available and not many variations are there, and lot much needs to be done in this area, because unless and until we are sure that the various platforms which are available for the measurement of antibody titers, they give you a definitive titer, then only we can say with the confidence that yes, we can define a protective titer. But at the moment, I think lot many variations are there, and lot many differences are there between different assay platforms. So I think maybe an microbiologist or immunologist will be able to answer this in a better way. But as far as I can say, that at the moment it is not that feasible to get to say that this assay is going to give you the protective titer or define the protective titer against COVID. So I think I have covered all your three issues which you have raised.
Yes. The reason I asked the last bit about the protective titer is, of course, that everyone wants to know. But also last year, America came up with this a big study that they had done on the West Coast, and they found out that those who had a very high titer of antibodies also suffered COVID very badly. Let us say that they had a morbidity was very, very high. Yeah. So is there an optimum protective titer? Would that be a conclusion to make out of that? I don't really.
I don't think. Because that's what I have also said, that, for example, the people who got infected, they recovered and then they were vaccinated with both the doses. Still, I know 2 or 3 people personally, and they went through a very bad bout of COVID thereafter. And one person known to me, he even died. So you can't say with confidence, because so many things are there which are yet to be known in this.
Yes. Thank you so much, Dr. Abbas.
Next question is for Dr. Ganesan. Sir, for how long do these antibodies confer immunity to us? And because we have lost so many doctors to COVID, even after successful vaccination with both the doses. So do you think 2 doses of the vaccine are enough for us, or do we require a booster dose, or how many doses do we need to confer immunity, especially in the healthcare sector?
First of all, I thank the organizers for giving me this opportunity to present my views to a larger audience throughout the country. Thing is, the first question is, for how long the immunity will last? I think the history of the disease itself is hardly about, say, 18 months. And we had our first cases in Chennai, something starting like in April 2020. And some of our staff themselves developed in May. In fact, in May to September, 19 of our staff members developed COVID. And in fact, many of them recovered and joined duty after about, say, anywhere between about 15 days to as high as 2 months. Then at that time, there was the antibody tests were not available. So we were not able to measure their human response or cellular response to antibody. But when the antibody test, I think the first one available to us was the total antibodies from Roche. We started measuring it right from March onwards. Then the next month we had the specific S protein antibodies from Roche. Then now we also have the neutralizing antibody from various manufacturers, and we are using currently the one from Chemotherapy. So as a study, we first thing is none of these 19 of our employees have developed COVID again. So I think probably that could have been due to the antibodies they have developed. And most of them, when we measured, 10 people had antibody. I am talking about the S protein antibody levels, about 250. In fact, we did not dilute because the company does not recommend diluting it because they have not yet found the right diluent. Then about 6 people had anywhere between 150 to 250, and the other 3 people had values between 50 to 150. But none of them developed COVID again. So we presumed that this S protein antibody provides sufficient protection against that. So if you ask how long, I can say maximum from last May to this June. That's roughly about 12 months. These people have been protected by the natural antibody. And interestingly, we did a longitudinal study right from March. Contrary to most of the publications, we found that in many of the candidates, the antibody levels are actually increasing.
Okay, sir.
And in some, actually, it is remaining the same. And in 4 candidates, the antibody levels are decreasing. But in fact, I think the other speaker said, I also do not have really a cutoff value, again, above which the antibodies will be protective. When I internally talked to Roche and some of my other colleagues abroad, they suggested that the S protein level of about 30 units and above may be protective, but I still don't have any proper evidence. So right now, to answer the first question is, the antibodies have protected for about 12 to 13 months. For how long this protection will continue is something we have to study. I hope if the antibody level does not fall or does keep increasing, I do not know how the antibody levels keep increasing. I do not know whether there's any remnant viruses or viral fractions that are still stimulating, or there's an auto-stimulation of beta cells in secreting antibodies. So it's a question of time. Right now I can talk only for these past about 12 months. So the first question is the minimum time the antibodies, as far as I know and I have studies, is about 12 months. And it's very likely that these antibodies may be protective as long as they are against a particular level. And that level has not been defined yet by any of the researchers or any of the IVD industry guys. The next question is, it's very, very unfortunate that many doctors got infected with COVID and many of them died. I really do not know. Yes. Even here, not only doctors, lot of people, in fact, during the second wave, that is this March, April, May, have been fully vaccinated. Fully vaccinated in the sense that they received 2 doses, and many of them had S protein antibodies well above the measuring limit, that is more than 250. But still, many of them developed COVID. In fact, I know at least about 4 people who died despite having both vaccinations and a very high antibody titer, and I am not able to find a reason for that. Why, first of all, they should have developed this, and why, again, they should develop such a serious illness with lung, pulmonary damage and other things. In fact, one person did develop a cytokine storm. I do not know the reason, but it's unfortunate that these people did die even after having both doses of the vaccine. But fortunately, it's a very small fraction. And unfortunately, it's the medical profession that was most affected after taking both doses of vaccine. In fact, I got infected after taking both doses of vaccine. Before taking the vaccine, I was I was pretty safe. But of course, luckily my course was very mild. So that's the third question is, I think it is about whether we will need an additional dose. It is again a very difficult question. As I said, we can keep on measuring the antibodies, and if the antibody level falls, we can give an additional dose. And already Pfizer has indicated that this is very likely to be an annual flu shot, like other flus. So at present, I am not very sure whether we will need an additional booster dose, and if at all we need, where it's going to be an annual dose, or it can be like once in 2 years or 3 years, or
like influenza doses.
Like influenza doses, or whether it will depend on the antibody level. These are the questions I think we'll be able to answer only in the future after doing the antibody levels, or after we know, we get a clinical history that even the people again, who have received vaccines are getting infected. So that's the question that I think I will find it very difficult to reply now. Okay.
Thank you so much, sir.
Okay. Yeah.
So my next question is to Dr. Abbas. Sir, is there any test that is available that can detect a person's immune response to COVID better than the antibody test? Any alternative tests available?
Yeah, there are, like, for example, I mentioned about the plaque reduction neutralization test for this neutralizing antibodies, which is available. But as I said earlier, that it is quite cumbersome. And but new tests are coming up, and I hope that in near future, because I think that the other arm of immunity, that is not the antibodies, the B cell, but the T cell response is also to be assessed, and neutralizing antibodies which you are doing. So in that component also comes. So that plays, I think, because I have seen that as Dr. Ganesan was mentioning just now, that many people, they got vaccinated, and when they went for the antibody titers, they were nil. So lot many disappointments and lot many concerns were there, and people were very concerned that what is the reason behind it. So I think that this role of the neutralizing antibodies is very vital and important, because the other component of the immune response, that is the T cells, we are as yet not looking for. And there is neutralizing antibodies are very important and vital. And I think that such tests, which may be coming in near future, will be helpful for knowing the total immune system or the immune protection an individual has. But as I said, that COVID, as of today, we can't predict lot many things, and lot much we have to know in times to come. So that's it.
Thank you, sir. Over to Dr. Priti.
Yeah, Dr. Kaur, sir is from Gangaram Hospital and is a pediatrician. Sir, a question for you. Why do we find the disease process to be much more mild in the pediatric population as compared to adults or the geriatric age group? So if you could answer this.
Before I start, I would, maybe you can put it in the panel discussion later, that whether the kits we are using for measuring the antibody titers, be it the total or the IgG antibodies, are they the right things to measure after the vaccine response? So are these the right kits? Maybe then somebody, the expert, can just give us an answer. Coming to my question, that why we saw very few children, not few children, less number of children as compared to adults and the elderly population being affected. I have the data here from the, which has come 2 days back from the ICMR, where they have segregated the data age-wise. In fact, the health minister had presented this. I have taken it in one of the webinars. So out of 29.6 million people who have infected till date, inclusive of total number of deaths, the pediatric population in the first wave and in the second wave is more or less same. This is solid data I'm talking about. 11.62% is the population from 0 to 20 years of age who have been affected in the first wave, and about 11.31% are in the second wave. So it's more or less the same. Now it is the question why children really were less infected. So this is really a $1 million question. I will not have a straightforward answer, but there are a lot of factors which are responsible for the causation of less number of COVID infections in children. One is that pediatric population, neonates especially, the infants, have a lesser expression of ACE receptors and TMRP, the transserine membrane protein receptor, which is a co-receptor for the coronavirus. And then there are other receptors which are important for docking of the virus. So the density, the number of receptors present on the pediatric cells, the epithelial cells, the mucosal cells, the respiratory cells are relatively less. So that's why possibly the virus is not able to dock properly and the viremia is relatively less in the pediatric population. These are all hypothetical. This is nothing, no scientific conclusive studies have been done to validate a randomized cross-control study. Second is that possibly children are affected with, to some extent, we see a lot of influenza virus or rhinoviruses, which are pediatric population infections. But they don't get coronaviruses infections early in childhood. But the adults over the years pick up other coronavirus infections, the non-COVID coronavirus infections, and possibly they are primed over time. And then once they pick up this coronavirus, it just leads to a flare-up of infections. Then there is a lot of things with the comorbidities. Adults have a lot of comorbidities like diabetes, like hypertension. They may be on chemotherapeutic drugs. So that's one of the reasons. Possibly children who are less than there, most of them are well-to-do. I mean, in a good shape of health. They don't have comorbidities. So that's one of the reasons. Then people have also speculated the role of BCG. In fact, there was a lot of an emphasis that if we could really vaccinate the adult population with BCG, could it make a difference? Because BCG is a vaccine which modulates the T cell response. Okay, so our whole concept of, I mean, what we are doing with the COVID business is looking just at the antibody response. We're not looking at the T cell response. We're not looking at the mucosal immune response. Now, there are a lot of papers looking at the T cell response and the mucosal response. Possibly the mucosal response is a little dampened in children. The T cell response is a little less in children. That's why they don't get the infections. But whenever they do get infections, they get milder type of infections. And if they get infections, they recover from the infections, and then later on, after 6 or 8 weeks, they present a condition called a multiple inflammatory syndrome. So we have a lot of pediatric population, children admitted in the wards who present with this type of multisystemic inflammatory syndrome. But as such, I would not pinpoint, well, this is the reason that pediatric population is less prone to getting the coronavirus infections. So it's all basically hypothetical. I think we'll have, somebody needs to do a very good comparative studies with in the pediatric population to look at this response. What's happening at the cellular level, what's happening at the basic, at the different levels. Thanks, Amit.
Absolutely, sir. Like you're right, more research is needed for all this, especially in the second wave also. We've seen more number of pediatric patients being involved. So I think time will tell us more about all this.
Yeah, I think time will tell us. We are thinking about that. We are speculating that third wave may infect this. This is just also a presumptive hypothesis that children are going to get infected to a larger extent. But if you see the data till now, about 50 to 55 to 55.7% is the pediatric seroprevalence rate. This is the study being done at AIMS, where they have shown in an adult population, the seroprevalence is about 63.5%. So unless and until we get a seroprevalence of about 70 to 80%, then we can say that, well, we may not have further infections. But I think it's very wrong to say that the pediatric population is going to get infected. I don't find any biological or scientific plausible reason for this.
Okay, thank you, sir. Now I would like to ask our oncology expert, Dr. Amit Bhargava. Sir, we know that patients receiving chemotherapy or radiation are immunocompromised. And how are cancer patients managed if they contract COVID-19? Just if you could just give a short overview on this.
Sure. Thanks for inviting me here. See, one thing, let me tell you that the severity of COVID infection is definitely much more in our group of patients as compared to normal patients. Now, the issue that we are facing is basically during chemotherapy and radiation when the patients are ongoing treatment. One thing is you have to protect them from infection, and number two, if they contact COVID, then there are so many issues that come. As far as the treatment part is concerned, we invariably follow the similar kind of a protocol as it is followed in non-immunocompromised patients. The only aspect is that when we are adding steroids, a good antibiotic and an antifungal cover is given to them right from beginning, and we keep a check on the neutropenia aspect of the patients. Because most of the patients who are on chemotherapy, they invariably have a compromised marrow as well. And neutropenia actually complicates the issues. Most of our patients who have contacted COVID and had a severe inflammatory reaction due to cytokine surge, and they're on long-term steroids, invariably land up with secondary pulmonary infections or secondary UTI or any other kind of a sepsis. So we have to have a protocol to prevent secondary sepsis in these patients. So what we invariably do, other than sending the routine investigations, our culture levels are routinely sent. And invariably for severely sick patients who are hospitalized and on any kind of an oxygen support or where the fever is continuously persisting, cultures invariably we send it on a weekly basis. In case if we find the cultures are positive, we give them antibiotics accordingly, or else, though time period has been just 18 months. So, there are no standard guidelines for managing secondary sepsis in oncology patients, but every oncological society has come up with some kind of a guideline where based on their data and the environment and where the infection is prevalent, they have come up with a set of antibiotics which we give empirically before we get the culture reports. Most of the time, the antibiotic that we use in our hospital is piperacillin tazobactam along with a fluconazole as a prophylactic measure till the time we get culture sensitivity reports. Rest of the parameters like especially patients who are on radiation. Now, radiation, the thing is that they have to come every day for radiation. Now, in case if they have contacted COVID, definitely they have to get a break from radiation. There is no way we can call them to the department because just for one patient, the whole set of patients on that machine suffers. Because then you have to clean the machine, you have to isolate the machine, you need to fumigate it for at least 12 to 24 hours before you take up the next patient. Now, the protocol that we are following in our department is basically we are for all chemotherapy patients who are coming either on a weekly basis or on 3-weekly basis. We minimal test that we do is a rapid antigen test or an RT-PCR. So if we test them as positive or negative, we invariably give them a break. If they are negative, we take them up for chemotherapy. suspected patients who are basically who have had or who tell us that they have had a history of contact with the patient, we monitor their parameters. We ask them to wait for at least 2 to 3 days post contact. In case if there is no fever, we call them, we do a rapid antigen or an RT-PCR. If negative, we take them up for chemotherapy. So that is the current protocol that we are following right now. But given a standard guideline, as you know, with rest of the antibody testing and other things, even in oncology, currently we do not have a very strong and straightforward guidelines which has been approved by any authority like FDA or our DCGI or WHO, which we follow. But it is just like oncological societies where we share our case-based studies, and then we have formed few guidelines. Though ESMO and ASCO has come out with certain, I would not say guidelines, but certain parameters which needs to be taken care of, which I just mentioned during a COVID pandemic in immunocompromised patients.
Thank you, sir. Basically, strict monitoring is required for oncology patients. Not just, it's actually required for all the patients, but special care has to be taken because they are immunocompromised. Dr. Ananya, over to you.
Thank you, ma'am. So for our next expert, Dr. Vimal Pahuja, our question is that sometimes we see that there is no antibody response even after successful vaccination. How is that possible? And is there a role of memory T cells in these individuals?
Thank you so much for having me here. First of all, I congratulate you for such a wonderful and informative webinar. And this question was already there, and people have been asking this question over and over again, that why no antibodies after the vaccine? And you must be knowing that there were some cases against the Serum Institute of India because there were no antibodies developed even after the 2 doses of vaccination. So the answer lies is there's no guidance as such to measure antibodies in any of the individuals who have got vaccinated. That is the first thing, because FDA has never said that you must measure antibodies, because there are 2 types of responses which we get after the vaccination. One is the cellular response and one is the humoral response. We all know that. And when you inject a vaccine, there will be a CD4 cells which are going to come into play, who are going to take up the antigen, and then they are going to stimulate the B cells and CD8 cells. And then hence we are going to see the humoral response following the stimulation of B cells, and you're going to get antibodies. Now, why there are no antibodies in some individuals is a very difficult question to answer, because there are a lot of uncertainties in this area as regards to whether the immune system vary from individual to individual, which is not able to produce antibodies, or there is something related to the route of vaccination which you adopted. Because of course, if you see the route of parenteral versus nasal, you will get a lot better antibodies because they are direct stimulation of tissue resident helper T cells or CD4 cells which are inside the lungs. And probably these are of course studies have been done, but they are very small studies, and they have speculations that probably this is a reason why you get a better antibodies than the parental route. So there may be a better antibodies when you get a nasal vaccine. There are papers coming on that, but we have to wait and watch. So the antibody, and second logic to this is when we are not sure what kind of antibody levels are going to be protective, why we measure antibodies. There is another logic to this one, that we don't know. We have to have epidemiological studies, look at the cutoffs where the people are not developing infections. Now, there are again the 2 issues in the antibodies also, where somebody described that even after taking the 2 shots of vaccines, Dr. Ganesan was saying that despite that the doctors died, why there is response, this T cell response, what you're talking about. The second part of the question comes here. The T cell response is very important, people. If your T cell response is good, your immunity system is, you are going to be immune to the virus. So there are Th1 response, there is a Th2 response. If the response goes in a direction of Th2, then you are likely to get a severe infection. But if the response goes in favor of Th1, which we have seen with the vector-based platform, sometimes the Th2 responses are more active, which is called as antibody-dependent enhancement also is seen. that was seen with the dengue virus vaccines in Philippines, where there are a lot of children deaths were reported. That is because of when you are exposed to the wild virus and we have never been exposed earlier, and then you have been already vaccinated. These kind of things are seen. Probably these are things are existing which we need to investigate in our population, because these are new platforms, vector-based platforms that have never been experimented except for the dengue and Ebola. So that is one important reason that T cell response becomes very important, and T cell response is going to be protective. Now, in the UK, they have done the studies, they have looked at the lymph node biopsies, and they have clearly shown that even though there are no antibodies in the people, the B cells, human B cells stimulated, they have this T cells against the neutralizing antibodies, means they are capable of producing the antibodies. And also there are studies which have shown that T cell, okay, there are specific T cells against S antigen. So they have been, after the injection of vaccine, you can see the T cell which is tagged with S antigen, CD4 and CD8 both. So T cell response becomes very important in a long term. It is shown that these cellular responses, T4 and the T cell response, is going to give immunity for years together. Probably this is what they are with the earlier vaccines. So T cell response becomes very important. Antibody response may or may not be, short way of telling you that you are protected. So no point in measuring the antibodies, and guidance are very clear about that. I hope I've answered the question.
Yes. Dr. Amit said that he's one of the examples of having a less titer post 2 doses. So, Dr. Amit, sir, would you like to add something to this?
Yeah, can I just mention, because, Fortis just did a study, our hospital, and it was published just 2 days back, where they analyzed all the doctors and the staff members who were vaccinated and who contacted COVID. So our data said that around 92% of the doctors and the staff, medical staff who got vaccinated were, when they got COVID, 92%, they, moved out with just very minimal symptoms. 6%, and all these 92%, they were managed at home. 6% of these patients had to be hospitalized with moderate to severe symptoms, but they could manage. And only 2% mortalities were noted in patients who were vaccinated with both the vaccines. Now, there was a discussion last week in our hospital that does the antibody body titers need to be measured, or does it make a difference in your COVID severity or in your outcome of COVID? Invariably, whatever data we gathered out, and for some patients we did antibody titers itself, including myself, my antibody titers were less than 1, and I protected. I somehow escaped the first wave and the second wave. Touch wood. I did not contact COVID at all. So I'm just hoping that I pass through the third wave as well. So, there are so many patients who are like me, who have no antibody titers, who have received 2 doses of vaccination. And in spite of having a COVID, they have low titers, but, they are kind of protected. Now, there is one point, if I have 1 minute, I'll just tell, then that stimulated my brain to think that, are there any Indian population or any kind of a population which have an innate immunity towards COVID? Now, there was a literature which was published by Dr. Biswal from West Bengal, where he mentioned about a protein sequence, which is AAT, adenine, adenine, and threonine. So what he said, that if that is basically an integral part of the ACE2 receptors, and if you have a deficiency of these AAT receptors, then the virus invariably doesn't penetrate the basement membrane. And that is a kind of a population which may have an innate immunity towards. So, and this, I don't know why this was not given too much of importance. In fact, there was a publication from US as well, that certain kind of protein deficiency, which is innate with Asian population, and they have developed kind of an innate immunity towards it. And that was one of the reasons which they mentioned, that the Asians and especially Indians had a lesser mortality with COVID. Now, even if you see today, you compare the number of population of US and versus India, our population is at least 10 times that of US. And if you see the mortality, I guess with that kind of a population, it's much less. I'm sure Dr. Pahuja would be able to, a much better person to comment on this.
Yes, of course, that mortality we saw in first or second wave, still is 1.5 to 2%. I think never does cross beyond that. And you can see the mortality rate about 10% to 13% in US and European countries. So that was a kind of mortality they got. But yes, of course, as Dr. Bhargava is very clear that this kind of sequence, I have also read that paper, that the sequence is important, and we have some innate immune system. We are innate immunity to the virus. There could be non-specific immunity to so many other factors like BCG vaccine, which we have like BCG vaccination. We have influenza vaccine. So there were so many other factors which were probably responsible for lesser infection in Indian patients, and also lesser mortality. I think they were in when the first wave was there were studies which came from the countries where the China had invested money, and they were all vaccinated before the pandemic actually started with MMR vaccines and MMR specifically. And they said there was a very less number of cases in those countries, and we Indians are all vaccinated with MMR. So probably and our vaccination drive is very higher than the European and US countries, because they don't accept vaccines very easily there, as compared to we who actually go get vaccinated. So probably that is also one of the reasons why we didn't have much of a severe infection. The numbers were lesser in comparison, in proportionately to other European and US countries, and mortality was lesser.
Thank you, sir. I'd like to bring in Dr. Ganesan into the discussion as well. And I want to ask him that if the immunity of COVID is largely humoral. Dr. Ganesan, sir? Sir, are you there?
I will just unmute. Yeah, good evening again. Yeah, it's
and how do we measure this
yeah, it's a very difficult question. I would like to agree with Dr. Pahuja that the protection that we get from vaccination or natural infection is probably both humoral and cellular. But right now we have a lot of ways of measuring the humoral immunity, like S protein antibodies or nucleic acid protein antibodies, or even the neutralizing antibodies, or the more cumbersome gene script antibody levels. So whereas we know that the protection is very likely to be both, as of now it's very difficult to measure the cellular immunity. We have to probably find out the specific T cells that have memory for so many different proteins of the SARS-CoV-2 virus that can sort of stimulate antibodies. So what some researchers in the UK have done is they have compared the T cell response to protein, neutralizing antibody levels, and the correlation was not really that great. So whereas I would say that the protection comes from both humoral as well as the cellular antibodies. Right now, the methods for measuring the cellular protection, how the cellular immunity is less. So we have to content at present ourselves with measuring the humoral immunity only. So maybe in future there will be methods to measure the cellular immunity. In fact, we did measure the CD4, CD8 count of the infected patients, which were very low when they had active infection, which again went on well with the NLR ratios. Then once they recovered the CD4, CD8 cells count returned to normal. But I think this is not sufficient to say that the protection has come from the T cells coming back to normal. So we will need more studies, more on T cells that have memory specific to various SARS-CoV-2 proteins. Okay.
That means there's a lot of research that we still need to do. It's a relatively newer disease. So yes. So
I think measuring humoral antibodies is a lot easier. Yeah.
Yes, it is. It is. Over to. Thank you so much, sir.
Yeah.
Over to Dr. Priti for the next question.
Yeah. Now back to vaccination. I would like to ask Professor Dr. Abbas Ali, is there a need for vaccination in patient who has recently recovered from COVID-19 infection?
Interesting question, and not many queries are there with regard to this. And I think there is a need that those who have recovered, they must go in for the vaccination, because it will give a booster. It will give a boost to immunity. And that's why I think it is recommended also that those who have recovered following COVID, they must go in for vaccination. But of course, after giving some time, it is still being debated that either 4 to 6 weeks or 3 months shall be given as an intervening period after the recovery from COVID. But I think this vaccination for those who have recovered is needed, and it will give a boost to the immune response, and it will give you more antibodies to fight subsequently. And that's why it is vital and important to go in for vaccination, even if you have the infection.
Thank you, Dr. Abbas. Now I request Dr. Vinita ma'am to take over.
Yeah. Good evening, everyone. I have an open question to all the panelists. We had a very good discussion on immune response. I want to know, is there any possibility that inactivated virus, that is the vaccine virus, can become activated and cause infection in a particular individual? So this is an open question to all the panelists. Anybody?
Well, I can answer it for you. As far as I will take the analogies from the pediatric vaccines, which we are using in most of the kids. Inactivated vaccines, killed vaccines, they do not replicate. So they are quite safe. They can be given even to immunocompromised individuals. So there is no chance then they will replicate, okay? Even the newer vaccines, these newer adenoviral vectored vaccines. So whatever adenoviral vector vaccines we are getting, we have the replicating vaccines and the non-replicating adenoviral vector vaccines. So what the Covishield is using or other messenger RNA vaccines, all of them are non-replicating vaccines. So you will, even if you give these vaccines to immunocompromised people, they will not cause any disease. It's like, I'll take an analogy from polio. Say, polio is the only, if you give a live attenuated vaccine, like in the oral Sabin's vaccine, OPV, there is a chance of developing paralytic poliomyelitis with this vaccine. But with the killed vaccine, with the Salks vaccine, you will not get a paralytic poliomyelitis. So it's very unlikely, not even theoretically possible, that these inactivated or these vaccines can lead to the disease itself. Is the question answered?
Yes, sir. Very well answered. This was, I think, a query more of a general public than medicals.
So corollary to the answer. Okay, can just add to the one point, because these questions arise because when the patients take vaccine, what we see generally, they come up with a vaccine-related fever, and when they do the RT-PCR after 5-6 days, because the fever is not subsiding, the RT-PCR has come positive. So that's the point. That's why the point has been raised here, that whether the vaccines are causing the RT-PCR positivity. But the question here is that whether they are also getting exposed to the virus simultaneously, and most of it is coincidence, because most of the patients who are taking vaccines, they are not turning up RT-PCR positive. So it is generally, it is a behavior which is determining that probably you are getting exposed to the virus, and probably when you are taking a vaccine, there's a stimulation, and probably you are getting into RT-PCR positivity, and then you get severe symptoms because the fever lasts for 6 to 7 days, 8 days. And we have seen other symptom manifestations also after the vaccine. So this is a point of probably the reason why people are asking such questions again and again.
I think
exactly.
I'll answer the question. Here, I think it is the RT-PCR coming positive has nothing to do with the vaccine. I think the patient must have been incubating at that point in time when he has taken. And that's when, after the incubation period is over, he's had a viremia. So it has nothing to do with the vaccine. And even the progress of the disease, the symptoms and all, also has nothing to do with the vaccine. It is because of the innate viremia or the innate disease which has caused it. And I would also like to answer Dr. Kaul's question, like in between he had asked that what are the antibody tests which should be done following a vaccination, or what the antibody tests which we are doing, are they right or wrong? Now, I would like to begin by saying that CDC has updated in March 7th of March 2021 that there are only two kinds of seroassays which can be done, which has been approved for emergency use. One seroassay is called the antigen binding tests. All the rapid tests, the point of care tests, the CLIA, ELISA, whatever we are doing, looking for total antibody, IgM antibody, IgG antibody, all of them are antigen binding tests. And out of the 232 antigen binding tests, FDA has approved only 50 of them. So we are choosing of those 50s and we are doing it. This is one. Second is the neutralization assays, as most of us have talked about. None at present, only one neutralization assay on ELISA format has been approved for emergency use for checking the titers. And that is a competitive neutralization assay, which many people are not doing, because it's very costly. That's the only neutralization assay which has been approved. All plaque neutralization assay, microneutralization assay, whatever has been talked of, nothing has been approved for patient care and patient testing. All are in research use. So whatever antibodies we are checking off, I think we are doing a good job in giving a total antibody test for diagnosing, and IgG for looking at the immune response generated following a vaccine. Now the cutoffs have not been defined, so we are trying to say, okay, this person has had an IgG response, so he is protected. And if his IgG is not there, that means he has got no response. That's a very small, it's a very small picture, because as Dr. Pahuja rightly said, that the cell-mediated immunity takes over. It's the antibodies, it stimulates the B cells to generate antibodies, but the B cells at times, especially in elderly group, don't keep on generating antibodies as we see in the younger lot. So you might have antibody negative because of the undetectable levels of the IgG. However, the memory cells are still in circulation, and in case the person encounters a virus, the memory cell will again start initiating or stimulating the B cells to generate antibodies, and then gradually the antibodies may be of that level that we can detect. So a negative IgG does not mean that the person is not protected. And there are not enough cell-mediated T-cell tests to be done. We know of only one T-cell test for TB, which we do, that's quantiferon. We don't know of any T-cell tests which are done in COVID or any other infection for that matter. So at present, we can't say that whether he's not protected because he's not generated IgG. He may be protected, but we are not able to check the T-cell immunity.
Thank you, Dr. Sanghamitra, for such a elaborative explanation. We will now shift to our questions on biomarkers. And my next question is to Dr. Abbas Ali. Sir, is there? Dr. Abbas,
I'm here. Yeah, I'm here.
So we all, I'm sure all the laboratorians have experienced a shortage of testing kits for parameters like D-dimer, IL-6, CRP, primarily due to the creation of COVID testing panels and blind repetitive testing in almost all COVID patients. Is it really necessary to do all these parameters in all patients?
Madam, I don't think there is a need, but I think in this era of Google and all that, Google doctors are available. Now people who are even not exposed to COVID, they are going in for getting their test done. So that is, I think, is not advisable at all. And we must educate the masses that they should be need-based testing, and that has to be there for anything and everything. especially in these times, in these testing times when there are problems in procurement of kits and all that, then it becomes more vital and important that such a test like IL-6 or D-dimer and all that, they have to be done if there is a need, if there is a reason for it. Otherwise, I don't think that unnecessarily just for monitoring or for going in for it, people should go on getting these tests done. So, but unfortunately, I have seen, especially in Lucknow, that the physicians as well as even the patients or their relatives, they were insisting on having such tests done, and unnecessarily lot many investigations, especially for these high-end tests, were being done. So I think there is a need that this fora like these, we must educate the physicians as well as the general masses that precaution should be taken, and unnecessarily don't go in for getting investigated until unless there is a need or cause for it.
So, Dr. Abbas, you mean only if the tests are abnormal in the first test?
Then only you should go in for. Otherwise, unnecessarily getting it repeated again and again and insisting on getting it repeated, that's not good, I think.
So only the abnormal test may be repeated to see whether they are getting normal. Otherwise, the entire panel need not be repeated.
No.
Yes. Okay, thank you. Dr. Vimal, I would like to know, how do you see these biomarkers essentially influencing the treatment strategies in COVID-19, and when should they be ordered?
Yes, I think I just take over from Dr. Abbas Ali's point that the tests actually are not necessary for all the people, because when, as a practical experience, I'm telling you, this COVID epidemic, I had opportunity not to see the patients only from Mumbai and Maharashtra, but also from the north, the south, because I used to get consult for second opinion because there was issues. And in the first instance only, I could see the people doing interleukin 6 levels and all the other biomarkers, which is absolutely not necessary for individuals. They are absolutely normal, mild COVID symptoms. There were panels defined and interleukin 6 levels were done, and the people are getting panicky because the interleukin 6 levels was high. So there were a lot of reaction to the test, which was actually the clinical application was not there. The whole reaction was to the laboratory test, and that's the problem with the defensive medicine what we are practicing currently in our country. Because we don't have anything else to offer, the reports and the treatments also, the defensive medicines comes into picture, and that's the whole issue. Now coming to our question about how the biomarkers will define our strategy, that clearly in the first, when the patient gets a mild symptoms, who's doing it from home, who's home quarantine, not many tests are needed actually. We just do a CBC, the CRP and the D-dimer in the first instance to see what is the baseline value of these tests. And of course, when I say about any test, any biomarker, we have to correlate clinically. So we are not reacting to any biomarkers jumping up. We are also looking at the clinical symptoms and signs and what this patient is complaining at this point of time. So that is just very important to read and then make a diagnosis that what is the treatment strategy for this patient. So only these kind of markers are necessary. You might repeat CRP or D-dimer once again after a few days, maybe 72 hours, to see whether there is a jump in CRP, because during the journey of COVID treatment, we see that after 7th, 8th, 9th day, the CRP jumping up, cytokine river, or whatever you say, the cytokines coming up, and the CRP, since a surrogate marker of interleukin 6, the CRP levels going up. And that only marker we have used to analyze that this patient probably is going into the cytokine storm, may go into cytokine storm, 6-minute walk test, other clinical symptoms. Looking at all these things, then only we have told the patient to get a CT scan done if required, and then probably need and necessary for steroids or other treatments. So biomarkers will tell you which patient is going to go into cytokine storm or likely to get hospitalized, likely to get what may get into hospital. So you plan ahead early, but there are a few biomarkers. Don't do all the biomarkers in all the patients, not necessary. and then you can decide what kind of treatment you're supposed to give to the patient. So this is why the biomarkers are necessary. Of course, there are certain biomarkers when the patients get admitted to the hospital, then we want to see the troponin I, we want to see the whether the patient's has got lymphopenia, what is the creatinine level of the patient, because these are the patients who are a little sicker, and all these markers which you're talking about tell you about the clinical severity of the case and will tell you whether the patient will have a bad kind of stay in the hospital.
Outcome.
We might increase outcome, may be bad for this patient. So that's why when you need all these biomarkers, we don't even do interleukin 6 levels till we see the patient is hypoxic and we are planning teclisumab. No interleukin 6 levels till you are actually looking to give tocilizumab to the patients. Till that time, we actually don't do any interleukin 6 level. No use, because CRP is helping you out. That is a good marker to actually assess the condition of the patient. Then also we do a marker called procalcitonin levels, because when we are looking at the secondary infections, the rate of change of procalcitonin, how procalcitonin is changing, will tell you whether the patient is susceptible or is having bacterial infections. And it's very important that we treat those infections, because we have lost many patients to secondary infections rather than COVID itself. So that is very important that we assess those patients, and it requires all clinical acumen, how to order a biomarker, which biomarker to order, when to order, and what to do with that biomarker. Now I've seen people having interleukins of 1500, but they're not hypoxic. Their oxygen levels are 98. So, and in some hospital with interleukin level of 1500, the people have started to give tocilizumab, though the patient is not hypoxic. So this is called a reaction to the biomarkers, which should be avoided. Biomarkers are to help you to guide the therapy, but in accordance to the clinical symptoms and signs. Thank you.
Now, I would like to now ask Dr. Ganesan, sir. Sir, how do we harmonize test results across various platforms or equipments? Like it's something to do with accreditation also, and how to ensure all this. So if you could throw a light on this.
This is an extremely difficult question. In fact,
Yes,
the American Association of Clinical Chemistry and IFCC has been trying to harmonize the test right from 1990s and not with much success. The reason being that, there are so many manufacturers and so many methods for a particular test. So I think it will be very ideal to have a harmonization, and but I think it's going to be difficult. Before that, I would like to agree with Professor Abbas and Dr. Vimal that currently in the COVID scenario, many of the biomarkers are being overutilized. And without harmonization, you can, imagine what kind of confusion it can cause in the patient's mind, with somebody, for example, doing a D-dimer by a latex agglutination and somebody doing a quantitative test using immunoturbidimetry. So I think the difficulty in harmonization comes because there is not much cooperation between the IVD manufacturers. In fact, the IFCC has conducted, in fact, I requested the big multinationals like Abbas, Siemens, Roche, and Beckman and other companies to have a simple test like, lipids, cardiac enzymes to harmonize long back, and that's not happening. So I think it's going to be very, very difficult to harmonize, particularly if, let's take for example, D-dimer. As early as 2005, the International Society of Thrombosis and Hemostasis formed a committee. And D-dimer itself being a mixture of various FDPs is going to be extremely difficult to harmonize or even measure D-dimer. And again, what is the real reference material? Do we really have a worldwide approved reference material to measure these newer parameters? That's another question. So even if we measure, then what are the different methods? In fact, some clinicians even don't look at the method. They just compare the numbers and get really confused, or they want an explanation. Sometimes actually it brings a disrepute to the laboratory unless you mention the exact method of you doing. So I think whereas harmonization desirable is again going to be difficult. Then again in 2011, the same ISTH formed a committee called FACT, Fibrin Assay Comparison Trial, to harmonize D-dimer assay. And they came across more than 23 quantitative, qualitative, and semi-quantitative assays. And till now, I think they are not able to come to a conclusion of harmonizing. So I think in the case of D-dimer harmonization, is going to be very difficult because of the multiple methods that are going to. At least in the case of IL-6, there are only two methods to the best of my knowledge, only the ELISA and the CLIA, and so many variations of CLIA like CLIA, E-CLIA, and CMA. But fortunately, at least a sort of cutoff level is agreed, above which that we can consider that there's probably a inflammation and the patient may be going to a cytokine release, if not a full-fledged cytokine storm. So I would say that whereas harmonization is preferable, as of now, it will be very difficult for us to establish it, particularly in difficult assays like D-dimer. Where, as I said, we have not even harmonized for simple tests like lipids or cardiac enzymes. Does that answer the question, or is it giving more confusion than really answering?
So actually, you have reiterated the fact that it's like important for all of us to correlate the results of the same test, though it's done on different platforms, because the units are different. And so that knowledge is required for the lab people also, and also the clinicians. Thank you. Now we go on. We have a couple of patient-centric questions for our expert panelists. So over to Dr. Amit Bhargava. I would like to ask you, is vaccination helpful in all cancer patients? And do we have any guidelines for this?
Oh, yes. At the outset, vaccination, we invariably try to vaccinate all cancer patients. Now, in first phase, when there was no vaccine, there was a few patients who were like allergy. We use one injection called as PEG-GCSF. PEG stands for polyethylene glycol. Now, there is a set of patients who are allergic to polyethylene glycol. And polyethylene glycol is one of the solvents used for most of the vaccines. So that is the only one category of patients who in oncology who are allergic to polyethylene glycol is the one we do not advise vaccination. Otherwise, as a blanket, we advise vaccination to patients who are being newly diagnosed, who have completed treatment, and who are on regular follow-up for cancer. Now, the issue comes when we talk of patients who are ongoing treatment, patients who are on treatment. Now, what is the timing for vaccination? When should they receive vaccination? How do you schedule vaccination along with the chemotherapy dosage? That is a very big issue. And as of now, we do not have any guideline. But, for practical purposes, what we do, we study the pharmacokinetics of a drug and we see what is the nadir time of their suppression of bone marrow. So that is one period that we avoid vaccination in our patients who are on chemotherapy. Otherwise, invariably, we advise everyone. Now, another situation comes that once you administer vaccine, these patients invariably tend to develop a kind of fever. So we do not want that fever episode to coincide with the neutropenic phase of the patient. Because if that happens, then we don't know whether it is because of the vaccine, because, anyways, we are facing a big challenge in managing febrile neutropenia. And when this is complicated by a vaccine induced fever, then, it further complicates. Either we end up over-treating these patients or, any kind of a complication that happens with these patients. We've even seen, kind of thromboembolic episodes being induced post-vaccination when they coincide with the febrile neutropenia. And we've even seen a lot of secondary infections happening and patients getting complicated either because of vaccination or because of, as one of the panelists said, that you may contact COVID at the time of vaccination, because that was one of the studies which came in, that when people go in for vaccination, they contact COVID because by that time they have not acquired enough immunity. So, there are a lot of unanswered questions for patients who are ongoing treatment with chemotherapy. I'm sure time will tell us what is the exact methodology. But as of now, we are just using, our basic scientific knowledge about the drug and its mechanism, pharmacokinetics and dynamics, to schedule vaccination for patients who are ongoing chemotherapy.
Okay. Thank you, Dr. Amit. Actually, there are many challenges involved, like you said,
Absolutely.
about neutropenia.
Absolutely.
My next question is to Dr. Vimal. There is an overflow of information via social media and the internet, which has led to COVID patients self-medicating and interfering with their physician's treatment protocol. How detrimental can this be, especially from the steroid point of view and in diabetics?
Absolutely. This has been the trend in this, especially in the second wave. And we saw a lot of drug shortage and a lot of other issues, and how the wrong messages went, how the steroids become very important as compared to remdesivir. Those WhatsApp messages saying you can treat with, when you can treat with a 30 rupee drug, then why you need to have a 1,000 rupee drug. So those kind of messages were actually detrimental as well. Now coming to the protocols, I have seen the prescription being passed from the pharmacist to the patients because somebody has done online consults. I have seen the prescriptions being passed on from the neighbors to the patients because somebody had suffered from COVID. So all these scenarios were seen in the second wave because they were not able to get through doctors. It's not that there was, a patient didn't want to approach a doctor or get a treatment, but there were no sufficient doctors available. And that's what happened, that people started sharing prescriptions and pharmacists also started treating in the same way. Now, what happened when they approached the doctor, they were already taking medications and there was a lot of duplication of medications. That was one issue which we saw, that duplication of medications, people were taking double dose of the drug, and that could have led to a lot of toxicity and people were suffering from side effects. That was one thing which we saw. Second thing, we saw that invariably everybody was put on black thinner right from beginning, which is actually not indicated. There's today the paper has been published on Lancet that prophylactic versus the prophylaxis versus the treatment part of the thromboprophylaxis point of view, whether it is helpful or not. And then it clearly shown that we don't have to do higher doses and of these direct thrombin NOACs, and not to use aspirin unnecessarily if there is no indication in this patient, except for the patients who are really moderately severely sick. They are likely to develop more of issues with the clots. So that is also what I was saying. Steroids were started right from the beginning on the first day. Now that message came because I thought there was a lot of shortage of beds. Again, there was a lot of shortage of oxygen. So what people thought, that by giving steroid from day one, we are going to prevent that people will not develop, hypoxia, and they will not require hospitalization. So that was actually again a defensive reaction. So whatever is there available, just treat, because the protocol claims that steroid is the only drug, no remdesivir, nothing. So that's what happened, that the steroids were started from day one. The ideal dose of steroid from the recovery trial, we know it is 8 milligram equivalent to dexona. So they use 6 milligram. It is 8 milligrams of dexamethasone here. That is equivalent to 64 milligrams of methylprednisolone. The dose from right from day one, the patient was not hypoxic, was in the tune of 80 to 120 milligrams. In the hospitalized patients, the steroids were used in the tune of 3 to 4 grams. In interiors of UPNDR, I've seen that 1 gram daily steroid dose. There was no standardization of the steroid dose. 250 milligrams daily. Somebody has used 1 gram IV steroids daily for 3 to 4 days. Therapy. So this was a scene which we saw with as respect to medications, which led to a lot of monitoring issues, where the people who were not diabetic, when we were given a very high dose of steroids and the sugars were not monitored, they developed a lot of secondary infections, diabetes related complications, diabetic ketoacidosis, hyperosmolar comas. They actually lost the patients not because of COVID, but just because of a very high dose of steroids, and unable to pick up in the right time that these patients are having hyperglycemic crisis. That is another issue. Secondary infections, we love patients with secondary infections, and we all know the mucormycosis, a saga in our country which happened. Mucormycosis, invasive fungal infections, so many other issues came up because of just these overzealous and abuse of steroids, and that led to a lot of unnecessary deaths which could have been prevented.
My next question is to Dr. Sanghamitra Datta. Madam, with the availability of home testing COVID antigen kits, it was quite publicized, and the immediate reaction, I think, of most of the people doing molecular was, what about the biomedical waste disposal? So what do you suggest? The home testing kit, how safe it is to dispose it of?
At the outset, I want to say a used COVID antigen test, rapid COVID antigen test is a biomedical waste. So never mix it with the general waste, even if it is done at home or in a quarantine center or wherever. Second is COVID-19 patients under home care shall store all these biomedical tests wastes in a yellow colored bag, which is provided by a urban local body. So you can go to the municipality corporation and get a yellow bag, and that's where you are going to store the used antigen kits. And this yellow, at the outset, you can decontaminate it using bleaching powder, because 1% bleach can decontaminate it at the disinfect it rather at the outset. Or if there is only not available, the bleach is not available, one can use 70% alcohol and disinfect it, put it in the yellow bag and give it to the authorized waste collector of the municipality who comes to pick up your waste. But the bag should be yellow, and a dedicated waste collector cannot deny collection of waste from a quarantine center or from a home care. So that is the method of disposal of these rapid kits which are being used at home. I hope I've answered it.
So, yes, you did answer it. So in places like in Madhya Pradesh, we have a separate agency from municipality for a biomedical waste. So municipality doesn't dispose of. So I think in states like this, they should have, for use of home kits, they have to first arrange for the disposal.
Yeah.
We have separate agencies for BMW and separate for municipal waste.
So
although it's the cleanest city in India, but we still don't have arrangements for biomedical waste by municipal.
So then
I think I'm not aware of other states.
You have to take the bag, the yellow bag, to the biomedical treatment facility operator. There must be a facility operator who operates the biomedical facility waste treatment. So you have to carry the bag there and give it. So that is the, the citizen has to do that.
So which is quite maybe impractical at times, and therefore, I mean, municipal has to work on it before they allow the use of these kits.
And you can't keep.
Dr. Sanghamitra, I also wanted to ask you about the Delta variant, which is so much in news now. How is it different from the other variants of COVID? And what is the difference between a variant and a mutant strain?
I think the next slide, I have the slides with it so that I can answer it well. The next slide, please. Yeah. So viruses, especially RNA viruses, they always undergo mutations to their advantage. Most of it is to their advantage to circumvent any kind of adverse environment they are in, be it a human immune response or anywhere. So they keep undergoing mutations. Now, a variant is a one wherein they have undergone mutations, following which they become distinctively different from the others. So that's when we call them a variant. Now, emerging variants have been circulating around the world since this pandemic. CDC and WHO has very nicely classified these variants into three groups. One is a variant of interest, variant of concern, and the variant of consequence. Now, coming to the variant of Delta virus, it comes under the variant of concern. Now, how are they different from each other? Next slide. Next slide, please. The variant of interest are those viruses wherein there is a change in the spike protein or the receptor binding domain, and following which they have reduced neutralization by antibodies which are generated by a previous infection or by vaccination. They have reduced efficacy to these monoclonal antibody treatments, and they have high transmissibility. The variant of concern, which is the Delta virus, next slide please, has significant reduction in neutralization. The previous one, variant of interest, had reduced neutralization, but this variant of concern has significant reduction in neutralization of antibodies generated by previous infection and vaccination. They have reduced effectiveness, significantly reduced effectiveness to treatments. They have diagnostic detection failures as well, and they have significantly increased transmission of severity. So Delta virus variant is one of its type, which is most transmissible among all the variants which have been detected till date. And the variant of high consequence we haven't yet encountered. It has it will be a variant which will be disproportionately large number of vaccine breakthrough infections and very low vaccine protection. And CDC then has to start looking for a new vaccine. So we haven't yet got this variant yet. Next slide, please. Now coming to the Delta virus, there are certain features of the Delta virus, which is, next slide. Do you have the next slide, please? Yeah, so these are the viruses, alpha, beta, epsilon, delta, and gamma. All these variants come under the variant of concern. And these are the ones which are showing the mutations, B.1, 0.617.2, which originated from India in the month of February, but now has swept UK altogether. As I have already said, the features, they have increased very high transmissibility. So very low amount of viral load can infect large number of people, and the multiplication factor is so fast that they cause overwhelming infections. So at times, these antibody cocktails, which have been now emergency used authorized, will not work on them. Next slide, please. However, MIT study claims that it is 40% more transmissible than the alpha variant. It has better binding capacities, and the low threshold of the virus can cause infection and help replicate efficiently. So the infected person will always have an increased viral load. But the good news is vaccines work in this particular strain. Next slide, please. So it is said that the Pfizer vaccine gives 88% protection to this particular variant, but Covishield gives only 60% protection. So we did see breakthrough infections of following vaccine and the second wave, because the Delta variant swept India in the second wave. But if you have one dose of the vaccine, it gives only 33% protection to this variant. So at present, the main answer to this is India has to, propel its vaccination drive so that we do get protection from at least 60% protection from this particular variant, which has swept UK now. And it has traveled to 80 countries in a matter of few months. So that is the transmissibility, and that is the infection. And that is the cause of post-vaccination infection. So there's nothing to do with antibodies not generated. It is one of these variants now which are coming up, which have got reduced neutralization to vaccine-induced antibodies. Thank you.
Thank you, Dr. Datta. I have an open question to the forum. How many waves do you think it is going to take? Are we following the UK now? This time the third wave you think is coming?
I think we should, the waves which come, they come with new variants. That's when the vaccine gets less protective every time we have a wave. So in order to not produce these variants, we have to limit the replication, because as and when the virus replicates, it mutates. And then as and when it mutates, it produces variants. So third wave can be stalled if we are conscious, and probably we can stall it if we are more disciplined. I feel that way. Rest, I think others can take it.
Just add to it. If you see the history of pandemics which have happened in the past, any pandemic has lasted for almost 3 to 4 years. And after that, the diseases have been coming in spurts. Now, this pandemic is slightly different from the rest of the pandemics, is that there were no vaccines available for the previous pandemics. For this pandemic, we have a vaccine. So what, my perception is that definitely these waves will come. If you see the first wave, which lasted longer, second wave lasted for just 3 to 4 weeks. The third wave, which may come, which may be even shorter. Because, what I feel is that the RNA virus, the more they are mutating for their advantage, but they're getting weaker and weaker, and their lifespan is life cycles are becoming shorter. So that is what I feel. And plus, moreover, these vaccinations again are going to reduce the cycle of these waves. And more vaccination, the way we go, we are going to have these waves which are coming in spurts, but the severity and the incidence will reduce with time. So what I feel is for next 1.5 years, we are going to go in such a way that we are having a spurt for 4 to 6 weeks, and then again it subsides. Then we have a calm phase for another maybe a month or 2 months, and then again the spurt comes in till the time virus takes to mutate.
Well, I wish we could have I'm in fact looking for an epidemiologist who could write a little write-up on the prediction of the third wave. But well, I'm not really an epidemiologist, but what I would say that, see, I was just, whatever data we have of the seropositivity, whatever little data we have from maybe 4,000, 7,000, 8,000 individuals where they have done a seropositive studies, the seropositivity rate is about 63.5% in the adult population. So whether this is, so unless and until we reach a seropositivity of around 80%. So we have to have 80% of the population to get the infection or the vaccine protection. Then only possibly the epidemic is going to die down. So it will depend upon a lot of things about the viral mutants, how we are unlocking ourselves, how the activities restart. So a lot of socio-cultural and biological factors are coming into play, but definitely within next 2 or 3 months, we'll see a resurgence in the infections, in the cases.
Yeah, I also agree with this, that until unless it totally dies off, the variants will come, and we will be seeing some waves in times to come. And we must continue to take precautions, and all precautions have to be taken. And that's very important and vital, because mask and sanitization and all that is very important for times to come, at least. So I agree with all the panelists that precautions are needed there. Thank you.
And this should not desist us from giving message to the public that they should get vaccinated, irrespective, whatever be the protection.
Certainly,
vaccines,
that's very important.
They should get the vaccination done.
I 100% agree.
We next move on to the interesting case which one of the surgeon from Indore has shared with us. In fact, it is Dr. Sudesh Sharda. He wanted to actually present his own finding, but he had to go to OT for a perforation case. Just now he was attending our meeting. So this was the case which I had received for histopathology. It was a 50-year-old male, typically presented with acute abdominal pain. We have in fact seen many such cases in past, and the histopathological finding was this. You can see a lot of mucor, and other than that there was inflammation. So we have, I'm sure, like we have, I get almost 4 or 5 cases every week in my tray of histopathology. I'm sure all of you across the country are getting GI cases also as a atypical presentation in mucor. So I would like the panelists to comment on their experience on mucormycosis.
I would like to share our experiences where we actually contracted. We had few cases from the periphery. In fact, from thousands of patients we have treated in the institute, we have not got a single case of mucormycosis till now. That is one thing. That is because maybe the strict protocols which we had in place. Second point, we had at least 8 to 10 cases of mucormycosis which were there. Most of them were having rhinocerebral orbital mucormycosis, which was predominant, associated, and these are young. Some were having diabetes was a problem with all the patients. Most people had steroid-induced hyperglycemia, which also created issues and resulted into the mucormycosis. Pulmonary mucormycosis was one case. and rest of them are typically rhinocerebral and ocular micromycosis, which we saw. All those patients again required amphotericin. Some patients wanted to isoconazole also as a salvage therapy. We had a step down therapy with isavuconazole, and they could, especially the disease was limited, that could be done in those patients. And when the amphotericin B liposomal was not available, we used deoxycholate complex amphotericin also, which worked. And but unfortunately, there was no rise in creatinine in all those patients. So that was one good sign when we didn't have a liposomal amphotericin in view of shortage of liposomal amphotericin. These were our experiences. We had one, along with mucormycosis, we had arterial stroke with complete thrombosis of internal carotid artery. So that was one combination of a severe mucormycosis with a severe stroke, which unfortunately we lost. And that probably was related to the mucor itself, where we couldn't save the patient.
Dr. Sanghamitra, will you like to add something?
We do see a lot of cases of mucormycosis, especially from doctors who are being, patients who are being treated outside by general practitioners. You know, they have been given steroids and they come back with, mucormycosis. And the samples which we get mostly are from the sinuses, nasal sinuses. Very few orbital samples also we have got, orbital tissue samples. And they are, once they are diagnosed, we don't do PCR, we just microscopy and culture. And most of them which are positive, they are being given amphotericin and their blood sugars are controlled. Some of them, they get well, and but they continue on their injectable amphotericin for 6 weeks, and then followed by, if they want to go home, they are given prosaconazole orally. And few of them, we did have mortality as well. So it is mostly seen on these video conferencing, you know, when they have these consultations, they take steroids, then, you know, then the monitoring of blood sugar is not done. And these are the cases which we are encountering in our hospitals. We do see them quite often.
So thank you, ma'am. One question that Dr. Priti Bijlani has asked is that, are there any indications of getting an antibody titer done before the second dose of vaccine if the patient turns COVID positive after the first dose?
There is, I'll answer. There's no indication of getting done because now the guidelines have been already laid that after the patient has had an infection, the second follows 12 weeks subsequently. Isn't it?
Yes, ma'am.
So that's the guideline which has been laid. So we have to stick to that. There's no point in getting an antibody done because anyway, following a natural infection, there'd be an antibody boost. So we will see an IgG which is, positive. So that doesn't, but the patient has to get vaccinated.
Patient has to get.
It is not that because she's got an infection, she won't get vaccinated, because in a vaccination, she'll get a directed neutralizing antibodies, as I had already reiterated before.
Yes, ma'am.
For following a vaccination, and that's what we need. We need the neutralizing antibodies. So he should vaccinate.
Okay, the next.
Another reason why we get vaccinated post-infection also, because there was clear studies and published in Lancet that if the population is 5%, 10%, 20% immune, already had a zero prevalence because of the infection, after the vaccination, the attack rate further goes down and the severity of the disease further goes down. That has been clearly published in the papers. It's a population-based study. So that's the reason, despite you had infection, you should get vaccinated as per the guidelines.
There's a question from Dr. Saurabh Malviya. Is asking that whether CRP, low albumin, low globulin, lower lymphocyte count are negative prognostic markers.
These are the biomarkers which we always do for the patients, and the studies, longitudinal studies, and these patients, right from studies from China or Italy or US, they have clearly shown that having thrombocytopenia, lymphopenia, high procalcitonin or high CRP, very high LDH levels in the initial phases, or high D dimer more than 2 milligram per liter, also is one of the negative markers that we have seen that translates into severe disease as the days progress, and the patient can go on oxygen or ventilators. So they have been the prognostic markers. And in one of our experiences, when we had one patient recently admitted with the platelet count of only 45,000, which we assume to be a dengue patient, because we have never seen the people with COVID-19 infection in the first wave with such a low platelet count. And it turned out to be COVID-19 infection. And this chap developed SARI after 10 or 11th day after infection. So all the time his platelet count got better slowly over the period of time, but he developed severe infection now going on 10th and 11th day, showing that thrombocytopenia and leukopenia, both were there, are the negative prognostic indicators, and you might get such a low platelet count in sometimes in individual masquerading dengue-like features.
Thank you, doctor, for such a elaborate answer. May I now invite Dr. Aparna to offer thanks to everyone on behalf of all of us and all the people who attended. It was an excellent seminar. Dr. Aparna.
Yeah, thank you so much. And I think we were thinking 2 hours will be too much, but it was not too much. I think we should have a part 2 very soon. Thank you so much. First of all, let me start thanking with Dr. Vijay sir and Lalu madam, without whom I don't think this diagnostic division would have come and, be born. Dr. Shankar Sen Gupta, who has been guiding us from Kaho division. Coming to our today's session, I think most important is Dr. Seema Bhargava madam and Dr. Ravi Kumar sir. Special thanks to Dr. Suvin Shetty, who has helped us in actually, conceptualizing this whole panel discussion. Our moderators, Dr. Vinita madam, Dr. Priti and Ananya, the new baby of this group. Very good. And our panelists, I think without whom this whole thing would not have, I'm getting feedback from all over India in the personal chats as well that it's an amazing session. Our special invitees, thank you, Dr. Seema and Dr. Vinita, to get these special invitees with such a short notice. And our delegates, without whom I don't think this would have really, shaped up in such a wonderful way. Last but not the least, our Kaho back, the people who are relentlessly working from the Kaho Secretariat, Dr. Sakshi and her team. Thank you so much, guys.